Welcome to the Inside the Boards podcast, the podcast dedicated to helping you learn to think like a question writer so you can study smarter, not harder, and succeed in medical school. And now here's your host, Patrick Beeman.
You're listening to an archived episode of our 2017 Study Smarter series for the USMLE Step 1 and COMLEX Level 1.
Yeah, so tell us a little bit about where you're at and in your career and what you do for Lecturio.
Great. So in my career, I finished my medical training in the United States, and I'm now a resident, actually, in the New York area. So I'm working through my pathology residency. For Lecturio, I help them with their medical content. So when they go in new directions or they're trying some new material, or right now we're focusing on developing our USMLE style questions. We want to grow our Qbank. So right now we help edit and develop that content map and find quality authors to help us write the questions, and then we kind of help our supervisors and help the rest of the Lecturio team integrate that into their programming.
Awesome. Yeah, and so what's your title?
My title, I'm a member of the Medical Advisory Board.
And how long have you been with them?
I've been working with Lecturio since I had some free time in fourth year of medical school. I don't recommend it for every medical student, but I'm kind of, I can't sit still.
Gotta keep busy.
Even after I had my appendix removed, you know, they wanted me to take a week off, and I couldn't deal.
You sound like most of us in medicine. So,
right.
Did you to look at your own pathology under the microscope?
You know, I didn't. I read the report, and they called it necrotic. So we were moving closer to perforation than I was comfortable with. But here I am. It all worked out.
Awesome. Well, on that note, I will say that Lecturio has asked us to advertise the fact that they are looking for more question writers, and you can send an email to jobs@lecturio.com to get more information on that. And there's probably no better way to increase your abilities in test taking than to become a question writer, to learn to construct your own USMLE style practice questions. So if you're fourth year, third year, even after you've taken step 2, learning how to write questions will serve you well throughout residency, and then as you become an attending, to take written board exams, and of course for USMLE step 3. The amount of study I put in as a resident, well, this happens to all residents, dropped considerably from medical school, but in preparation for in-service exams or even my board exams after residency was probably half of what it had been in medical school, hour for hour, since I had done so much in terms of writing and editing multiple choice practice questions. So if you're interested, send an email to jobs@lecturio.com and you can work at Lecturio. But today, let's get into some pathology questions. These are the sorts of things that I think a lot of people in clinical medicine get removed or are far removed from, except for the pathologists who still, I guess, engage that content a lot more than people who are, in surgery, in OBGYN, in pediatrics. I suppose the dermatologists do a bit of this as well, but pathology is sort of the step 1 clinical specialty, the specialty that is most relevant to step 1, I would believe. The step 1 specialty par excellence. And I guess that's proven by the fact that the inimitable Edward Gullion himself is a pathologist, and it seems like a lot of medical educators fall into your specialty, especially those who teach medical students early on.
Yeah, we like to call ourselves like we teach the doctors, or we teach other physicians. They come to us with their questions, and we help them understand what the disease, the etiology, or help them develop a good pathway to treatment and therapy.
Yeah. Plus, your specialty probably is the most commonly represented specialty amongst, television and movies. You know, there's always a pathologist being consulted by the police or whatever in, crime shows and whatnot.
Right. Right. That new Will Smith movie, it's like 2 years old. That Will Smith movie, I guess, Concussion.
Yeah.
I think the original story was kind of organized by a pathologist.
Awesome. All right, let's get into this. We're going to start with a little warm-up question, more of a recall than anything. So I'll read this stem. We have a 14-year-old male who presents to the emergency department with severe abdominal pain, nausea, and vomiting. He's disoriented to time and place and shows small breathing. Abdominal examination showed generalized tenderness without guarding or rigidity. And his vitals include a normal blood pressure and pulse. His labs show a random glucose level of 628. His pH is decreased. His PCO2 is decreased. Serum ketones are positive. His serum sodium is decreased. Serum potassium is elevated. And serum bicarbonate is decreased. Which of the following glucose transporter is non-functional in this person? And I will say that I'm kind of doing a different approach in terms of reading the numbers in complicated stems with lots of vitals and or labs, and that is to note decrease or increase for most of them. At any rate, answer choice A is GLUT1, B GLUT2, C GLUT3, D GLUT4, and E the GLUT5 transporter. All right. And the correct answer is what here?
The correct answer is D, GLUT4.
All right. I'm just going to confess. I read this and I was like, what are the glutes again? To me, they are a muscle that one works out in the gym by doing deadlifts.
That's right. That's right. And this other thing.
Yes.
So these glucose transporters, super important to get glucose into the cells. And some of them are constantly working, like in the brain, in the red blood cells. And some of them are regulated carefully by the body. So in this patient, we have all these indications of elevated blood sugar.
Yeah. And
he's not using that blood sugar. So now he's breaking down his fats, turning them into ketones. Those ketones are causing a metabolic acidosis. It's resulting in his heavy breathing. He's trying to remove carbon dioxide from his blood, so resulting in that small breathing.
And the decrease in PCO2, if I recall.
That's right. That's right. Rapid breathing reduces PCO2. Perfect. But why? Why? What's going on? Well, he's not using his blood glucose effectively. He's using his fat. So that all kind of points to some sort of diabetes, some sort of diabetic issue. Perhaps he has diabetes type 1. Perhaps he has diabetes type 2. Well, in diabetes type 1, these are usually found in younger patients, and we have a 14-year-old patient here, where their pancreas is not producing sufficient amounts of insulin. And that's the hormone that regulates the GLUT4. It upregulates expression of the GLUT4 transporter on the cell membrane, right?
Yep.
So,
sorry to interrupt, but then I guess, is this the pathophysiology more of a type 1 diabetes because they lack insulin more than have insulin resistance, or no?
Right. Type 1 diabetes.
I guess I'm saying, is this a decreased functioning of the GLUT4 transporter? Is that a pathophysiologic mechanism common to diabetes in general, or more specific to type 1?
It's more specific. Well, in type 1, the lack of insulin precludes the expression of GLUT4 on the external membrane of the transporter. In diabetes type 2, the receptors for insulin are no longer responding to insulin. So even if there's a certain level of insulin produced by the pancreas, you're not getting that response to express the GLUT4 transporters. And that results in an insensitivity to your insulin. And this is found in older patients, usually with consistently elevated blood glucose level.
Yeah, that makes sense. But I interrupted you. What were you going to continue saying? Sorry. Hope I didn't ruin your train of thought, derail your train of thought.
Totally gone.
Totally gone. That's fine. So I guess the takeaway here is, and in your opinion too, I guess, of the GLUT transporters listed here, GLUT4 is probably fair to consider the most important one to remember for step 1 type stuff?
Yes, if you're talking about diabetes,
yeah,
GLUT4 is your go-to. But the GLUT1 is also super important, and GLUT3 is super important. These are constantly active. They will consume any and all blood glucose available in the blood.
Okay.
And then, but these other ones, like some of these other ones, are also relatively important. But the GLUT1 and GLUT3 will consume any blood glucose available, while GLUT4 is regulated by insulin. So, it depends on what the question.
Yeah. So GLUT4, I imagine, mostly found in which tissue then? Spread all throughout the body, or?
The majority, it's all throughout the body, but when you think about glucose intake, we're also thinking about muscles. We want to get that glucose into the muscles, and that's how we're regulating this. GLUT4 is also regulated by exercise. You can increase your expression of GLUT4 a little bit by exercise.
Okay. All right, cool. Any other high yield points you can think of from this little warm up recall question?
No, I don't think so. I think it's best to move forward.
All right. So the next one we have is a 3-year-old male is brought in because the parents notice that his skin is becoming yellow. He's awake, calm, and looks healthy, except for a yellow tone of his skin and sclera. The mother said the boy eats well, has normal stool and urine color. He was born of a healthy pregnancy and delivered vaginally without complications. His serum testing shows a higher value of unconjugated bilirubin. Complete blood count is within normal limits. The mother mentions that her sister died as an infant, but doesn't know the diagnosis. The only thing she knows is that her sister had an exchange transfusion. The baby is treated with phototherapy, but the jaundice only becomes more apparent and unconjugated hyperbilirubinemia persists into the second week of life. What is the most likely diagnosis in this case? A. Gilbert or Gilbert syndrome. B. Neonatal jaundice. C. Crigler-Najjar syndrome type 2. D. Hemolytic anemia. Or E. Crigler-Najjar syndrome type 1. And the answer here is
E. Crigler-Najjar syndrome type 1.
These types of questions are annoying when you've got maybe you're reading through it and you're thinking, oh, I know this is Crigler-Najjar, right? And then you get to the answer choices. It's type 1 and type 2.
Right.
So how do we keep that straight? Well, I guess first, what is Crigler-Najjar? Remind me.
Right. This is a genetic disorder of bilirubin conjugation. Now, recall that in the liver conjugates the bilirubins and then passes it into the bile system into the duodenum and small intestine, and then some of that bile is actually reabsorbed and some of it is passed in the stool. But here we're talking about a genetic disorder where the conjugation of bilirubin is not efficient. But this is type 1. And in type 1 Crigler-Najjar, it's the severe type.
Okay.
Right? So you have type 1 that's severe, that will get worse over time. And then you have type 2, which is less severe and might cause a transient jaundice, that yellow discoloration of the skin, jaundice. Crigler-Najjar type 2 might have a transient jaundice. Type 1, the more severe type, would have a worsening condition.
Okay. I guess you can remember that by noting that type 1 is primary, so the primary Crigler-Najjar to worry about would be type 1. I guess that might be a useful mnemonic.
Absolutely.
All right. Remind me then, choice A was Gilbert syndrome. What is that different? That also causes an unconjugated hyperbilirubinemia.
Right. This is one of those benign conditions as well, but it's usually discovered later in life.
Okay.
Yeah.
And then neonatal jaundice, that's usually seen, and that was choice B, is usually seen the first 5 days of life with the unconjugated hyperbilirubinemia that does not persist into the second week of life. And I suppose this is the one that is most often treated with phototherapy and which actually works, right?
Right. It works very efficiently in neonatal jaundice. Other types of jaundice, not so efficiently.
Okay. And then hemolytic anemia. This is a complicated topic, if I recall, because when I was going to med school, I was actually reading Robbins' Pathology, and I just remember these maps of the different hemolytic anemias or anemias in general. And I do know, I guess, can we talk a little more about the unconjugated versus conjugated by looking at the stem? In terms of bilirubin, like in the stem, for instance, it mentions that you have this yellowing of the skin. Is it true that this is kind of a clinical sign that's more common with unconjugated hyperbilirubinemia than conjugated? Am I remembering that correctly or no?
So, the purpose of conjugation is to increase the solubility of the bilirubin. Okay. So if you conjugate it, it becomes soluble, it's easier to transport, but it also doesn't precipitate out of solution. Okay. So to my understanding, jaundice is more associated with unconjugated bilirubin. Because it's unconjugated, it is more likely to precipitate out of solution, it is more likely to bind to other tissues, and it's more likely to result in discoloration, such as this jaundice. And you would also see it in the eyes, you'd see icteric discoloration in the eyes. And then, of course, we're also really concerned about precipitation of this material in the central nervous system. Potentially could result in death.
Okay, so I guess an easy way to think about the pathophysiology is if the liver is the sort of gatekeeper for conjugation, and the liver's job is to conjugate the bilirubin, dump it into the hepatobiliary tract, eventually the gut. In order to have an elevated conjugated bilirubin, you're looking at some sort of obstructive process beyond the liver doing its job. So, like a duodenal obstruction. Is that correct? Or, what else do you see it in? Like biliary cirrhosis, I guess?
Right.
Is that correct?
Yeah, I think that those are definitely closely associated, definitely.
Okay. All right. I'm not going to say any more about bilirubin because I'm an OBGYN and no one should have to learn the hepatobiliary system from me. Any other high-yield points here we could note for kind of like step one content?
No. For step one, this is, remember that the difference between type 1 and type 2. Remember the all the steps associated with the breakdown of hemoglobin into bilirubin, transport to the liver, conjugation at the liver, and then excretion into the biliary system, into the small intestine, and then a portion of that, of course, gets reabsorbed, and some of that passes in the stool. All of that whole system, that whole cycle is very important, and any disease that can disrupt that cycle is very important for step 1, step 2, and beyond into clinical practice.
Gotcha. And I will say, in the Lecturio Pathology course, there are, in the gastrointestinal pathology subset, there are 132 videos, 9 hours duration total, but there are 14 videos for pancreatic biliary disease and another 30 plus for liver. And specifically,
yes, those are our lecturer is Dr. Raj. He's fantastic. He
I see that he's called the kind of like the new Golion.
I've heard that. Yeah, he's also if you sit through one of his lectures, he grabs your attention. He's incredibly dynamic, and he flows very well from topic to topic to topic. And it's high quality material. It's very high yield.
Yeah. And I guess specifically what I'm trying to point out here is it's probably worthwhile to study all the things you mentioned here, to find some resource that really breaks down all of the complexities of the conjugation, or how the body deals with bilirubin in general. So, and one of the free lectures on Lecturio's platform is a 4.5-minute take on conjugated hyperbilirubinemia. So that would be well worth getting a subscription or an account with Lecturio and walking through that prior to your step 1 or during that second year time when you're learning this stuff. So, all right, let's move on. These next questions are a little more complicated in terms of their stems, so just bear with me here. The next is a 29-year-old woman who presents with a 2-hour history of sudden onset severe mid-epigastric pain that radiates to her back and also has profuse vomiting. The pain is unrelieved by antacid therapy, and she has no history of abdominal pain. She regularly consumes alcohol and recently finished off her 3rd bottle of vodka for the month. On examination, she is uncomfortable with a blood pressure of 95/40 and a heart rate of 105. Her lung examination reveals crackles at both lung bases. Abdominal examination reveals diffuse tenderness in the whole abdomen with marked guarding, rigidity, and hypoactive bowel sounds. A chest x-ray is normal, and an abdominal CT scan reveals peritoneal fluid collection and a decreased attenuation and diffuse enlargement of the pancreas. Her laboratory findings show a mildly elevated AST and ALT. Alkaline phosphatase is elevated. Amylase and lipase are likewise elevated, with a calcium of 7.1, which is decreased. Which of the following cellular changes is most probable to accompany these findings? And the answer choices here are, oh man, some of these bring back terrible memories. A, caseous necrosis. B, dry gangrene. C, colliquative necrosis. D, coagulative necrosis. Or E, fat necrosis. All right. These are hardcore pathology terms. So what's the answer here?
Okay, so we're dealing with the pancreas. We're dealing with acute pancreatitis.
Okay.
So the answer is fat necrosis.
All right. So fat necrosis, the kind of like necrosis that's found in pancreatitis, and also, if I recall, you see this in step 1 questions after somebody's had trauma to the breast tissue, like somebody gets punched in the breast and then has this like darkened kind of lesion following the trauma. Is that the same process or a similar thing?
Similar process. You have trauma to the adipose tissue, releasing enzymes that kind of digest that local area. Like you said, it can occur in the breast and result in some sort of like lytic lesion that they might find later, perhaps on a mammogram or during a self-exam. And that might cause like the whole process of evaluation and ultrasound or FNA or exam. But so trauma to the breast can result in fat necrosis. But in pancreatitis, it's much more extreme. The pancreas is full of these enzymes. And once you start irritating it with alcohol or a stone, a pancreatic stone, a biliary stone, all those enzymes just become active. Another way to irritate the pancreas is elevated triglycerides or elevated calcium. It just activates all of those enzymes in the cells, and then they just start digesting the pancreas. Now, when I do an autopsy, sometimes it's really hard to find the pancreas because it looks just like a piece of fat.
Yeah.
And there is a great deal of fat associated with this organ. So in this case, we have acute pancreatitis. We have all of our levels are telling us that, there's something happening. The lipase is elevated. So there's enzymes leaking into the system. The calcium is low. That indicates that the calcium is actually precipitating out of solution.
Yeah. And is that the term kind of we hear, like fat saponification?
Right.
Okay.
That's right. Right. And it'll form this like a white precipitant in that area. And you'll actually see that on in the pathology on slides. Absolutely.
Okay.
But these other choices are also quite interesting, speaking as a pathologist. This caseating necrosis.
Yeah.
Caseous necrosis, right? That should make you think of tuberculosis. You should go right to tuberculosis. It's the caseating granuloma. That's what we're talking about here.
And are these gross descriptions or microscopic histopathologic descriptive terms?
These are histological terms. Okay. Some of these, like the caseous necrosis, you will find a gross finding. There is something to see grossly when you approach the organ, and it'll be like this cheesy, friable material. But then when you look at it under a microscope, you're also going to see, giant cells, and you're going to see, a necrotic center of this ball of inflammatory cells. Then you can say that this is a caseating granuloma.
Ah, right. Yeah, I do remember that. I think that point you made, caseating necrosis, in my mind, the first thing that is associated, if this were a Rorschach test of pathologic terms, I would have said tuberculosis.
Perfect.
So, what about dry gangrene, which was choice B?
Real quick, just to go back to caseating granulomas, sure. It can also be caused by funguses. So different fungi can cause that. So it's not just for tuberculosis. If we find a caseating granuloma in a lung, we do testing for Mycobacter tuberculosis. In fact, any Mycobacter. We also do fungus testing, and we look for both.
Like histoplasmosis, trying to think what other notable fungi.
Aspergillus, stuff like those.
Okay.
But it's a non-specific stain, so anything that is like spore forming or hyphae forming should stain positive with the material we use. Yeah.
Okay. All right. I won't ask you to get into all of those because that's why you do a 5-year residency, right? To learn all those tissue reactions and how to make these things show up and diagnose.
Pathology is a 4-year residency now.
Oh, is it?
Yeah, and because it's a 4-year residency, they like us to do 2 fellowships. So by the time we're done, we're usually board certified in anatomic and clinical pathology, and then we'll have at least one, usually 2 fellowships. Yeah.
That sounds terrible. No, I'm just kidding. I thought I wanted to do GYN oncology. Which is originally why I went into OBGYN. But at the end of my 4 years, I was like, I don't think I can be a trainee for another 4 years, and do gyn onc. But, okay, let's move on. Dry gangrene.
Dry gangrene. So, this is a type of coagulative necrosis, and we'll get to coagulative necrosis in just a second. But there's something else. There's like an inadequate blood supply, like some sort of peripheral vascular disease. I just saw an example of dry gangrene. It almost looked mummified. Ugh. The tissue, it was a above knee amputation, and the toes, they looked mummified. They looked dehydrated. The tissue was a blackened Escher, and it was just mummified. It's the best way for me to say it. Dry gangrene, think mummification. See coagulative necrosis. Coagulative necrosis, you might know better as liquefactive necrosis.
Ah, yes.
Right. And when you think of liquefactive necrosis, the first organ to think of is the brain.
Okay.
The brain.
And I do think that here's a good point too. Sometimes you will be on a test, and you might know the process by one of its names, like liquefactive necrosis, which to me seems more common. But sometimes there is I guess knowing the synonyms for something is also very useful. So coagulative necrosis, liquefactive necrosis, these are synonymous terms.
Right.
And okay, so liquefactive necrosis, brain.
Right.
And then the final D was coagulative necrosis. Tell us more about that.
Sure. So you have tissue breakdown, but when you look at the tissue histologically or under a microscope, it appears like normal tissue, except it's all dead. So all the nuclei will be gone, but you can still make out vasculature. You can still make out architecture of the cells in relation to each other, but it's just that all the nuclei have been removed, and this is due to protein denaturation. There's so much protein in cells as they go through the process of dying. That protein can sometimes just break down and then reform new bonds non-specifically, and that helps stabilize the architecture of the cells and of the tissue.
Okay. And this is what you see in like a myocardial infarction, correct?
Right.
Okay.
Like the tougher organs, you'll see this a lot in. Like we talked about liquefaction necrosis in the brain. You have fat necrosis in the breast and the pancreas. This is for like the heart and the adrenals and the kidney. It's really tough organs here.
Okay. One's doing a lot of the work.
Right.
All right. Any other high-yield kind of pearls for necrosis?
I would focus on these are relatively straightforward questions, and I would focus on this word association. Mm-hmm. Caseating necrosis or caseating granuloma, think tuberculosis or fungus. A non-caseating granuloma, so this is that ball of cells where the nucleus is still viable. That could be a variety of different diseases. That could include sarcoidosis. That could certain vasculitises develop into non-caseating granuloma. So make sure, put those word associations together early, so that when you get to the exam, you'll read liquefactive necrosis and immediately think brain.
Thank you to Rao Reynolds and Enter Shikari for letting us use the track The One True Color off their 2015 album, The Mind Suite. As always, thanks for listening. If you like what we're doing on the Inside the Boards podcast, please subscribe to our show and leave a rating and review on iTunes. We sure appreciate it. Good luck studying. See you back next time.